and attended both college and medical school in St. Louis. He then went to the East Coast for all of his surgical training, first at George Washington University and then later to Rutgers Robert Wood Johnson. After a stint in private practice, then he moved to the Midwest and joined the University of Kansas Medical Center and Health System in the Division of Colorectal and Oncologic Surgery. He is a fellow of both the American College of Surgeons and the American Society of Colon and Rectal Surgeons, and he is active locally as a member of the ACS Kansas chapter. Outside of work, Dr. Luca enjoys playing golf, craft cocktail making, and spending time with his wife and two large dogs. He's joined this evening by Dr. Al Rajabi, who's an associate professor of medicine in the Division of Medical Oncology at the University of Kansas Medical Center and leads the GI Medical Oncology Group. Dr. Al Rajabi received his medical degree from the University of Jordan and proceeded to complete his internal medicine residency and chief residency at St. Vincent's Charity Hospital, Case Western Reserve University in Cleveland, Ohio. He then completed his hematology oncology fellowship at the University of Texas Health Science Center in San Antonio. His research interests include clinical and translational research in GI malignancy. He moved to Kansas then in 2013, where he joined both the University of Kansas and the Kansas City VA Medical Center. He developed a multidisciplinary liver cancer clinic to serve affected veterans, and then in 2016 transitioned full-time to the University of Kansas Cancer Center to lead the GI Oncology Group and expand the GI research program. So thank you so much to the two of you, and I'll turn it over to you both.
Great, thank you very much, Jen.
Thank you.
So as Dr. McAllister said, myself and Dr. Al Rajabi, obviously our main focus is oncology of the colon and rectum. As a colorectal surgeon, I do treat benign disease processes as well, but a lot of our practice here at KU is with the oncologic process, and obviously work very closely with our medical oncologists in the GI division to treat these. So tonight we'll be talking a little bit about locally advanced and metastatic colon cancer, because this is rapidly evolving field, and the treatment strategies are changing what seems like month to month for more advanced cancers after what had seemed to be kind of the standard of care staying the same for a while. So this is obviously a multidisciplinary field, so requires a multidisciplinary talk, which is why Dr. Al Rajabi agreed to join me tonight. We didn't have a radiation oncologist join us, but we will go over a little bit of that. Obviously, it is a very multidisciplinary approach, more these days than others. So you can see our disclosures there. So what we'll be going over tonight is, again, a little bit of the background of what the standard of care is right now. Just about colon cancer in general. We'll be focusing only tonight on colon cancer, as colon cancer and rectal cancer do start to evolve more and more separately from each other as the treatment strategies get wider and wider in those two fields. And so tonight we'll just be doing colon cancer. So we'll give you some background on that and the current standards of care, and then we'll talk about where different treatment modalities are starting to evolve as far as both locally advanced and metastatic colon cancer. We will talk a little bit about surgical techniques. While those have remained the same for a long time, there are some slightly different, newer strategies that are being looked at as far as specific techniques or properties of parts of the surgeries that we do. We will give a highlight onto any research that we're doing currently at KU. Again, most of that is led by Dr. Al Rajabi and his colleagues. And then, of course, we're happy to take any questions at the end. So just starting with a little recap of colon cancer. As you guys know, it is the third most common cancer in America, both for men and women, behind prostate in men and breast in women, and then behind lung in both. It's been third. The numbers may change a little bit, but it's been third place for a very long time, despite all of our advances in endoscopic surveillance and all of that. So it is a very common cancer. What we quote our residents and med students when we're teaching them and our patients that you still have about that 1 in 20 chance of getting colon cancer lifetime, anywhere between 4 and 5% for your average risk patient. So it's very common, and we obviously have a very large practice here at KU, unfortunately, for the amount of colon cancer that we do see. So these numbers are just a little bit dated, that's from 2021 is the estimated new cases. I just looked yesterday or the day before for the estimated new cases for 2023, and it was almost exactly the same. It was about 150,000 over the past several years. Those are the estimated new cases, and that turns out to be more or less pretty accurate when we look in retrospect every year. And the relative survival rate is more or less the same. So for all comers over the past 10, 15, 20 years, it's right around 2/3. So we're doing a pretty good job with all comers. Obviously, stage to stage, that's going to fluctuate, and we'll get into that. But it is a very treatable. We won't get into the prevention aspect of colon cancer tonight, but it's a very treatable cancer, even when you start getting into stage 4, as we'll see. But again, the later we get into the talk, the more you'll see that these evolving treatment strategies are putting more and more spins on the treatment and getting more and more length out of people's disease processes and extending their lives as long as possible. So again, we'll go through a little bit of the risk factors. This is mostly just to reinforce the point that the majority of colon cancers that we do see are sporadic and wild type. 65 to 85% is even a little bit on the low ball. I think we're taught in colorectal fellowship that it's closer to that 85%, and a very small percentage is hereditary or familial, along with the FAPs and the other very rare things you'll see. Where this will come into effect later on in our talk is that there's been a lot of advancements in how we treat the majority of the hereditary or familial, because they tend to have a different genetic sequencing. And so we have had a lot of advances in the last several years with different immune therapies and things like that, which look very, very promising both for colon and rectal cancers. And those are where you tend to see those different genetic variations in the hereditary or familial cancers. But again, the majority that we're all going to see are the sporadic or wild type. So this is an interesting slide. Like we talked about, the 5-year survival for all comers is about 2 out of every 3. You can see there for stage 1, we're pushing 90% for 5-year survival. And of course, stage 4 is somewhere in the 10 to 15% range. Those numbers can go up depending where the metastases are, whether they're liver, whether they're lungs, whether those liver lesions are resectable, or the lung treatments are, or the lung lesions are resectable, or you can radiate, things like that. That can push that survival anywhere up to 20, 25%. You can see there that even for the late stage 3 diseases, you're well over 50%, which is great. The interesting about this thing about this slide, and we'll get a little bit into that later, is as you can tell, the stage 2B cancers have a worse prognosis than even all the stage 3 diseases. And a lot of practitioners and patients are kind of unaware of that, and it's a little confusing when you look at that. If there's no lymph node involvement, why would the outcomes be worse for those patients? And so we'll get into a little bit as to why, but that will kind of drive some of our treatment strategies as to when we start having decision trees to make for those locally advanced stage 2 cancers. That's where we're going to get into some of these different treatment strategies and when to operate versus when to have neoadjuvant treatment and delay operations and things like that. And so, again, as we get into this, the goal kind of tonight is to talk about, how to treat these patients with your goal of cure, ideally. When we talk about stage 4 cancer, it's always a tough conversation, of course, to have with the patients that, we do consider stage 4 cancer incurable, technically speaking. But these days, the treatment algorithms are so wide and spread out and so individualized and tailored patient to patient that, while technically speaking, the goal isn't the cure, what we do tell a lot of these patients is that we can turn an acutely deadly disease into more of a chronic illness. And that's the goal. If we can turn this into an illness that we can treat for years and years and years and years, and hopefully extend their life with, again, what we hope is a good quality of life, turn into a chronic illness versus a fatal illness. That's the goal. And so, tonight we'll be focusing on the cure, what we hope is a near cure, if you will. I just made that term up. It's not in any of the books, but we won't be focusing, so much on the palliation. But as Dr. Al-Rajabi can probably delve into more, when we talk about this decision tree, obviously when we're talking about surgery, we're talking about a cure, or what we hope is a near cure when we're talking about resection. But when you see these patients, those are the 2 roads you have to travel down, either cure or palliation. And then if you're going for cure, Do you trust the primary? If you do you do it before treatment, or do you go with neoadjuvant treatment? And then if you're having chemotherapy, whether it's before or after, what regimen you go through, plus or minus immunologics, plus or minus radiation therapy, all of those things. And so Dr. Al-Rajabi is going to go through a lot of those algorithms, how we've come to the treatment strategies that we treat patients with today as our standards. How did we get to those points, and why do we use those chemotherapeutic agents? And then we'll kind of go from there.
So I'll be talking about locally advanced disease, and we know that stage 3 colon cancers benefit from adjuvant therapy or preventative therapy, but there are subsets like the patients with microsatellite unstable disease. We don't really know what to do when they have stage 3 disease. Stage 2 is just like Dr. Luca alluded to. There are certain populations that actually have a poorer outcome than stage 3s. And how do we identify those patients and who would benefit from adjuvant chemotherapy in that group? Those are a lot of questions that we've tried to answer over the years. Now, we know since the 1990s, since I think the 5FU was first invented in the 1960s, but since the 1990s, we know that giving 5FU to Duke's class C disease or stage C disease, that was equivalent to our stage 3 right now, did improve or decrease the risk of dying from cancer and decrease the risk of recurrence. But we couldn't identify if there was benefit in stage 2 disease. So so this study, the Quasar study, was developed, and it was one of the largest stage 2 colon cancer studies, where we randomized patients that had a clear indication for chemotherapy versus patients that didn't have a clear indication. They were kind of randomized to 5FU boluses plus minus different doses of leucovorin. But some of the stage 2 patients were put on observation. And as you can see, the absolute improvement in survival wasn't that great. It was only 3.6%. So stage 2 disease, even after the Quasar study, really there wasn't a strong indication for systemic chemotherapy to prevent recurrence. But we always strive to improve, and we tried adding more drugs to see if that would improve our adjuvant therapies. That led to the development of the NSABP C7 study, where they used a 5FU bolus versus 5FU bolus and oxaliplatin, which is another chemotherapy drug that we use frequently in colon cancer. And this study really didn't show an improvement in overall survival between the two groups. So oxaliplatin didn't improve things, but disease-free survival, which is a very good surrogate marker, was actually favoring the patients that received the oxaliplatin. And it was also, if you looked at the age groups, patients that were younger than 70 actually derived a higher benefit from the addition of oxaliplatin. But going on to the Mosaic study, and this is the seminal study that put oxaliplatin as standard of care in our treatment in adjuvant therapy. This was mostly stage 3 patients, some stage 2 patients that were randomized to receive FOLFOX versus 5FU leucovorin. And this study was designed and showed a very good favorable decrease in risk of recurrence, improvement in survival, favoring the oxaliplatin group. Now, it still did not show an improvement in overall survival in all of the stage 2 patients, but they had a subset analysis looking at high-risk features, which included large tumors that perforated, certain tumors that weren't adequately resected with low lymph node yield, or other things like lymphovascular invasion. And we could actually see an improvement in survival in those high-risk patients. So that led to, this is the final overall survival curves. And you can see the red here is the stage 3 patients that received just 5FU by themselves. This is the stage 3 patients that have oxaliplatin and 5-FU, so less risk or more survival, of course, less risk of recurrence. And you can see both survival curves for stage 2 are overlapping. But this, like I said, established the use of oxaliplatin as standard of care in patients with stage 3 disease, and to consider it in patients with high risk stage 2, because in stage 3, it actually decreased the risk of death. Now, after this study, we tried different biologics, adding EGFR inhibitors. We added bevacizumab. We even used irinotecan, a different drug, and none of those studies showed a benefit in overall survival. So this has remained the standard of care since the MOSAIC trial. Now, we went back to the MOSAIC study once again when we discovered the microsatellite instability, and we found that patients that had stage 2 with microsatellite instability had a poorer outcome with chemotherapy, and that also led to a change in the standard of care. So one of the major important studies in adjuvant therapy in colon cancer. So, like, just to reiterate, the predictors of benefit for chemotherapy includes positive lymph nodes, perforated tumors, large obstructing tumors, stage 2 or T3 tumors with lymphovascular invasion, poorly differentiated tumors, circumferential resection margin positivities, or less than 12 lymph node analyzed. Now, unfavorable to chemotherapy and where we should avoid chemotherapy are patients that have T1 or T2 tumors, T3 tumors with microsatellite instability, like we talked about, and patients that have T3 tumors with without resection, without high risk features. So that's kind of how we are developing or deciding on adjuvant therapy. Now there's more to come on this. In breast cancer, they're way leaps and bounds ahead of us, where they have cancer type ID and they have OncoDX and a lot of predictive markers, and we're starting to do that in rectal cancer and colon cancer, but still not ready for prime time. So we know that 6 months of chemotherapy is a standard of care in stage 3 cancers, and chemotherapy, of course, is not easy to tolerate, and you develop about a 15% chance of permanent grade 3 neuropathy after 6 months of FOLFOX or XELOX. Those are the two combos that we use the oxaliplatin in. This was the IDEA study. It was developed to, and it was a multinational study to look at 3 months versus 6 months of chemotherapy. And this is a good question that comes up after resection of a lot of these tumors. And so this IDEA trial had about 12,000 patients. And it did show that patients that got 3 months of chemotherapy, whether it's FOLFOX or CAPOX, had a much lower rate of long-term toxicity. So, but is this decrease in the toxicity equivalent, or is this chemotherapy of 3 months equivalent to the 6 months chemotherapy? The IDEA study was actually a negative study. It showed that the 3 months of chemotherapy was not non-inferior to 6 months. That's a double negative in patients. So it wasn't equivalent. But then they started looking at subgroup analyses, and we know how tough that is with large studies like this. But I think the numbers here would definitely support a subgroup analysis. And they actually stratified the patients to 2 risk groups. One is the low risk group and the other is the high risk group. And low risk group included patients with T1 to T3 with only N1 disease versus T4 disease or N2 disease. And you could see that there may be a trend here or a signal where the patients with low risk disease are not crossing the non-inferiority threshold that was set by their statistical analysis. So let's look a little bit deeper into these 2 groups and determine who would qualify for 3 months versus 6 months of chemotherapy. So looking at disease-free survival in the risk group, the low risk group here, T1 to T3 and N1 disease, FOLFOX, unfortunately, does always cross the threshold. So FOLFOX is always inferior if you give only 3 months of chemotherapy. Patients that are going on FOLFOX, I always recommend considering 6 months of chemotherapy. Now, look at CAPOX. CAPOX in the low risk group was actually non-inferior and could potentially be an option in patients that have very low risk disease. And this is something we usually discuss post-operatively to figure out if we could minimize toxicity. What about the high risk group? Can CAPOX prove itself there? Well, FOLFOX definitely failed again. So you definitely want to continue with 6 months. But CAPOX did cross the threshold here of non-inferiority. But you can see that the 3 months versus 6 months, 3 years disease-free survival wasn't that much different. So a lot of folks really think about, at least in the low risk group, a lot of people are comfortable offering 3 months of CAPOX or 6 months of FOLFOX. But in the high risk group, you could potentially consider 3 months of CAPOX. It's not as equivalent as 6 months of therapy of CAPOX. But what I tend to do in this case is I usually at 3 months discuss it with my patient, see how they're doing with their toxicity, and maybe consider just continuing 5-FU by itself if they're starting to have a significant amount of neurotoxicity from oxaliplatin. So moving on to local tumor control, and I'll leave that to Dr. Luca.
Yeah. So, what do we do with some of these patients? You can see that the survivals are, disease-free survival, overall survival. They're not great with these high-risk T2s, or I'm sorry, high-risk stage 2s, right? So if we went all the way back to the first slide, which we're not going to do, but we went back earlier, we remember that for those stage 2Bs, the outcomes are worse across the board. And why is that? And we have to look at what that means physiologically and surgically for these patients. Lymph nodes we can take out during surgery, relatively easily. They're part of en bloc with the resection. And, we can see the numbers show that anybody with lymphadenopathy, they're going to get chemotherapy and they're going to have at least some benefit, even these microsatellite patients with microsatellite instability. If they're lymph node positive, they have been shown to have a benefit from adjuvant standard chemotherapeutic agents. Plus or minus, we do add those immune therapies, but even before we have the immune therapies, they do benefit. And so these patients with stage 2 disease, with these big, bulky T4s that for some reason, don't have positive lymph nodes at the time of surgery, they tend to do way worse. And so surgically, we have to have an explanation as to why, or at least start to come up with a reason why, so that we can come up with some hypotheticals as to how to make those numbers better, how to give those patients better disease-free and, of course, overall survival. So we talk about local tumor control. We're going to talk about the margins first. We'll get to the lymph nodes later. But there's a lot of studies. I'm only highlighting a few studies here, but where positive circumferential resection margin. So we talk about that with rectal cancer. It's actually circumferential. When we talk about with colon cancer, it's basically an equivalent for local invasion. So depending where that tumor is, whether it's invading the liver or the gallbladder or the spleen or the bladder, is what we see most commonly with sigmoid cancers involving the bladder. Any positive resection margin circumferentially is associated with a vastly significant lower overall survival, disease-free and overall survival on pretty much any which way analysis that's ever been studied. In this specific study, the second one from, I believe it was Europe. Sorry, if we can go back one more, right? That study, the overall relapse rate, which is their term for recurrence, was almost 20% with the R0 resections, but that tripled with your R1 resections. And so every analysis that you do shows that it doesn't matter how much adjuvant therapy you give the patient, if you don't get a negative margin and an R0 resection up front, the patients do significantly worse. And so now we're starting to try and explain why those stage 2 patients, those late stage 2 patients, do significantly worse than any stage 3 patient. Okay, thanks, Ryan. So when we talk about what to do now, how to downstage those patients, right? Because if we're trying to get to a negative resection margin, we know how to do that with rectal cancer. So we downstage with chemotherapy and radiation. That's been the standard for a long time now. So how do we do it with colon cancer? Is there a role for neoadjuvant chemotherapy and or radiation with these patients, especially these late stage 2 patients? So the first trial that came out, we're going to talk about 2 different trials, both the Foxtrot trial and the some people say Protege, some people say Prodige, the 22 trial. I quite honestly don't know. I wasn't at the conference when they presented, but both of these trials had the same upsides. Both of them had very similar designs, and unfortunately, both of them had the same limitation study designs, which we'll talk about. So first was the Foxtrot. So this was a 2x2 study. There was a third arm, and this was, again, similar with the Protege trial. There was a third arm where they added immune therapy, but those we kind of just ignore those arms. So it's basically randomized trials comparing patients who got adjuvant chemotherapy only. So they got their standard 6 months, their 12 cycles of adjuvant after surgery, versus patients who are randomized to getting some of the chemotherapy upfront neoadjuvantly, and then your standard oncologic surgery, and then the rest of their chemotherapy afterwards. And so obviously the patients had to be fit for both surgery and chemotherapy. They had to have a biopsy confirmed malignancy somewhere in the colon. Again, these are colon cancer studies only, not colon and rectal. And then again, the main limiting factor for these studies was, how do you stage these patients up front? Again, rectal cancer, we have MRIs, we have endoscopic ultrasounds. They're not perfect, but they're pretty accurate. With colon cancer, we have our CTs. And so we were trying to predict, are these colon cancers T3 or are they T4? And do they have extramural extension just based on CT scans? And so obviously the patients who had their surgery first, and then we could accurately stage them and give them their 12 cycles of chemotherapy. Patients who got the neoadjuvant therapy, we had to rely on the CT scans to stage them with these preoperatively to see if they were amenable to the neoadjuvant arms. So if we go to the next slide, we'll see some of these outcomes. So we can see that their primary outcome was not necessarily what we were looking for. And so we'll get to that. But based on their results, so they decided that neoadjuvant chemotherapy was safe, and it downstaged enough patients to allow for more R0 resections, which again is what we're looking for. If we can get an R0 resection, we know your outcomes are going to be better. And so they noted that the patients who did get the neoadjuvant chemotherapy, they had more R0 resections. There was no increase in complication rates from surgery. They did have a substantial tumor downstaging, right? So they got T4 tumors down to T3 and N2s down to N1s and so forth and so on. Obviously, then the control group, because the control group received no treatment. And they did have mild to moderate tumor regression. And so size of the tumor and all of that, based on imaging. You look at the CT scan, if it was a 4 centimeter tumor, you get it down to 3 centimeters or 2, which is not, maybe it doesn't have any clinical outcomes, but the rest of their outcomes, they were favorable. Sorry, if we can go to the next slide. There we go. Sorry. So the recurrence rate was what their primary endpoint was, right? So recurrence rate, not exactly disease-free survival, but pretty almost equivalent. And so they did reach their primary endpoint, significantly lower recurrence rate in 2 years in the neoadjuvant chemotherapy group than in the adjuvant chemotherapy group alone. So 17 versus 23%. The problem with this is that, their main outcome was not overall survival. This was a 2-year follow-up on this study versus obviously our standard is 5 years. We usually look at 3 years and then 5 years, and there has been follow-up from this recently where the numbers do start to converge a little bit more. So as you're getting out to 3, 4, 5 years, these differences in recurrence rates are not hashing out as much as you'd like. But the initial numbers were good. The problem was the study was not powered for for overall survival, for 5 years of overall survival, and things like that. The other significant problem with this study that we'll talk about, or a limitation, I should say, is that, again, like I said, we're relying on CT scans to stage these cancers preoperatively. What they noted, and then I'm going to say the exact same thing about the Protege 22 trial, was that in the patients that did not get neoadjuvant therapy, they just had their oncologic resection. In about a third of those patients, the staging was off. They were staged too high. So in about a third of the patients where they thought it was T3, it was actually T2. And obviously a bunch of those patients did not end up getting chemotherapy adjuvantly. Whether they thought it was T4, they thought it was N2, it ended up being T3 or N1. And so obviously there's no way to know that with the patients who had the 4 cycles of the neoadjuvant chemotherapy. And so if a third of the patients were upstaged preoperatively in the adjuvant arm, we can only assume that a third of the patients, unfortunately, were erroneously upstaged before receiving their neoadjuvant chemotherapy, and then obviously subsequent surgery. And so what do we do with these numbers? It's a third is a pretty large amount. And I think that's why we're seeing later, as we get to 3, 4, 5-year follow-up, that I don't believe the 5-year follow-up has been published yet. But the numbers are starting to converge a little bit more, and those differences are not quite as much in those 2 different arms. And so if we look at the next slide with the Protege 22 trial, it's actually a very similar study. So phase 2 trial, multi-center with high risk T3 and then T4 and or N2 colon cancer. So they either got the 4 cycles and then the 8, or they got the all 12 cycles adjuvantly after surgery. And again, these are pretty much the same. It does show that 3-year overall survival was about the same, because this was powered a little bit differently, and overall survival was one of their primary outcomes. 3-year disease-free survival, there was no statistically significant difference. There was a trend in better time to recurrence. You'll notice that it's not exactly the same. So not necessarily the recurrence rate, but the time to recurrence was longer with the neoadjuvant arm. Again, not statistically significant, but there was a trend. But again, I think that'll hash out that if you do look at the 5-year survival eventually, disease-free survival, they'll probably end up being equivalent. And again, they also had a cetuximab arm, which they noticed no benefit over standard chemotherapy. And so these 2 trials were really trying to hash out, these patients with bulky lymphadenopathy, or if we get a T4 lesion, is there a benefit? And so far, while there's been some promise, and there are a lot of ongoing studies now, we have yet to see a really significant benefit to giving upfront neoadjuvant chemotherapy. I'm going to argue a little bit later, as we'll see when we get to the radiation side, that I think, maybe the numbers don't hash it out yet, but my opinion, and obviously I spoke to Dr. Al-Rajavi about this, he'll chime in as well. There is a subset of patients where I do think there is going to be a very good benefit, but that's going to take a lot more statistical analysis and a lot bigger numbers that we've had so far. So that's as far as chemotherapy. If we go to the next slide, we'll see that there was a big database study to look at all of these studies. So there was systematic review, and this was actually right before Protege and Protege trial and the Fox trial came out. This was a systematic review of the 6 studies that were published previously. And while the neoadjuvant chemotherapy did result in tumor volume reduction, that downstaging, if you will, there was the only significant rate that they noticed. There was a lower death rate or higher overall survival, you could say, in the T4B group. And so there was no benefit for T3 group. There was no benefit in the T4A tumors. They only saw benefit. And so that's kind of hashed out what I think, not obviously, it's still very equivocal. But I think that if you had enough numbers in Foxtrot or Protege 22, you may see that subset analysis where overall the numbers don't show a big swing. But I think in that very select subset of, again, these are the positive circumferential margin patients, these patients with tumor crossing and invading adjacent organs, or invading into the retroperitoneum or your psoas muscle or wherever, those patients, they had a benefit from chemotherapy. And you can see that 23% higher overall survival in that small period of time. And so these are the patients that I think we're trying to downstage again to get your negative circumferential margin only. I think if they don't have a threatened margin, you're not going to see that benefit. So it all comes back to being able to have that negative margin in R0 resection. And so if we look at the next slide that I believe has to do with radiation therapy, that's the same idea. And so there was a large database trial, and they looked at all of these patients who had clinical T4 disease from the National Cancer Database. And obviously a very small percent got neoadjuvant radiation. It's not something that we typically use in colon cancer. It's very, very select patients. And so you can see that in that small group of patients that did receive that, they had a much better R0 resection rate, and their 5-year overall survival was increased, by a good 15%. All of these numbers were statistically significant. And so, my argument would be, even though the numbers don't specifically hash out in any of the larger trials that we've done, I think that there is a clear, I shouldn't say clear, in my opinion, is that there is a worthwhile benefit in considering neoadjuvant, both chemotherapy and radiation where applicable, if it is, of course, in a spot where the patients will tolerate radiation. If it's a T4B tumor with or without obvious lymphadenopathy, I think that's where we're going to see the benefit with concurrent both neoadjuvant radiation and chemotherapy. And if radiation is not an option, then at least the neoadjuvant chemotherapy, whether it's 4 cycles and then 8 adjuvantly, we may see a trend in those very selective patients to do like we do with rectal cancer, is maybe we give 4 to 6 cycles and restage with imaging and see if we can then get a margin. And if not, continue to give neoadjuvant. Because again, this is a very small subset of patients, but I think that's where the benefit's coming in. And that's where you're going to see your survival benefit in those T4B patients. Do everything you can to get an R0 resection. And so last but not least, I believe in this section is, again, we've been talking about all these patients are wild type so far. So as we've alluded to earlier, what do we do with these microsatellite unstable patients? And so these are not necessarily all your HNPCC or your familiar hereditary patients. It is where we see a bulk of them. But again, standard of testing now on any proven malignancy for colon or rectal cancer is you should reflex, send the tissue samples for MSI testing. And so when you do come back with these subset of patients that are MSI high, what do we do with them? Now, again, some of this research is stemming from our rectal cancer studies. So those came from, and Dr. Al-Rajabi is going to go into more detail on this later, but when we had metastatic colon and rectal cancer, obviously we're kind of just throwing everything we can at them originally. And so a lot of this data came out of the metastatic cancer patients. Once we noticed that there was a good response, we went on to rectal cancer patients. And now I'll go short of saying it's standard of care, but it has made it into the NCCN guidelines that for rectal cancer, we do go first line with immune therapy because of the high response rates early on in our research and what we've been seeing clinically with these patients. And so there's only been one. I kind of scoured the literature over and over and over again. I've only been able to find one study so far for colon cancer only. And so this was a small study out of Europe with these patients, 32 patients, and they had microsatellite unstable tumors, as it were. They were not metastatic, they were resectable and colon cancer only. And they were treated with 3 doses total of immune therapy. And then they underwent surgery 6 weeks later. After about a 2-year follow-up, you can see that, initially, there was a pathologic response observed in 100% of the patients. So not a complete pathologic response, but a very significant downstaging of the tumors when they resected them and they took a look. 31 of the 32 patients had a good pathologic response. Only one had a kind of a very weak response, but there was a complete response observed in 22 out of the 32 patients. So 70% of the patients had no residual tumor after just 3 doses of immune therapy for these microsatellite unstable patients. And in the 2-year follow-up, the median of 25 months, none of the patients had any recurrence. And so in this very small single analysis, we are seeing very similar response rates with microsatellite instability in colon cancer as we've seen with rectal cancer. And so this very well may be the treatment algorithm going forward with more studies. You know, microsatellite in MSI high colon cancer patients may go the way of rectal cancer, and this may turn into a non-surgical disease for that. Again, that small subset of patients who do have these genetic markers. So that could be the future here, again, sooner rather than later.
All right, and I'll talk about metastatic disease. And we know that metastatic disease has a very poor outcome. From what Dr. Lucas mentioned in the past, you're really looking at double-digit survival in these patients. And the goal is to ask ourselves, how do we convert these patients to somebody that could potentially be curable or have no evidence of disease, or at least stay off of chemotherapy for as long as possible. And the multidisciplinary approach is really the way to go. That has the best outcome. And not only do we use systemic biological therapies and immunotherapies, just like Dr. Luca alluded to, but we're also using local therapies like surgery, microwave ablations, and radiation, and sometimes regional therapies to convert these patients into resectable candidates. We are noticing that colon cancer is becoming more and more multiple diseases in one, and we're personalizing therapy as we go along to improve outcomes, decrease toxicities, and hopefully get patients to a place where there is no evidence of disease. But you can see the genomic profile in colon cancer is very diverse, and it's most commonly seen as the RAS and PIK3CA mutations. Only about a third of the patients are RAS wild type, where they can get an EGFR inhibitor. But then you have these subsets of BRAF, MSI, POL, HER2 amplification. All of these we've developed a lot of really good treatments for, and we'll talk a little bit about some of this. But here at KU, we tend to do reflex testing on all our patients that are metastatic. So anytime there's a biopsy that shows colon cancer, patients are tested for KRAS, NRAS, BRAF, MSI, HER2, and NTRK fusion. These are all very good targets that could help us really affect their outcomes. And like I said, we're really realizing that CRC it's multiple diseases in one, and we'll talk some more about that in the next few slides. But this is kind of the timeline of what we had, and of course our 5-year survival, even metastatic disease, has improved over the past few decades. With the beginning of 5FU, we started adding more combinations together. They're doing more chemotherapy, adding more biologics. But I think we started looking at personalizing therapy in colon cancer around 2017. That's where we became more specific and looking at the unique profile of some of these cancers, with targeting things like MSI high, like we talked about, NTRK fusions, BRAF mutations, and other types of immunotherapies. So when we see a patient with unresectable disease at the beginning of their journey, we talk about neoadjuvant chemotherapy in some of these patients that we hope to convert. And there's risks and benefits to neoadjuvant therapy that we know are things that we have to discuss with our patients. Of course, the risks include, if patients get chemotherapy, they may progress on their chemotherapy. But, in our minds, a patient that progresses on chemotherapy may not benefit from surgical resection, even if it was possible in the beginning. Chemotherapy causes organ dysfunction, especially in the liver, and that's one of the highest areas of metastasis. And you want a healthy liver at the end of your surgery. sometimes chemotherapy is too effective, or target therapy is too effective, and these tumors kind of melt away and you can't find them, and they'll have a very high chance of recurrence. And of course, chemotherapy has toxicity, and we have to discuss that in detail. Like we talked about, anyway, we could test the biology of the disease. Some of the borderline lesions, from the benefits of chemo, include making some borderline lesions resectable. It could maybe convert a very large surgery to minimally invasive. It treats the micrometastatic disease very early when you start with neoadjuvant chemotherapy. And then you also predict the response of therapy post-operative. So we do a lot of sandwich therapy. So when you know that the chemo is working the first 3 months, it'll probably wipe out the micrometastatic disease after surgery. So it kind of predicts the trajectory of what to expect. And these are the treatment combinations that we use. These are doublet therapies: FOLFOX, FOLFIRI, and XELOX. We've also found that triplet therapies, including all of the drugs up front, has a higher response rate and improvement in survival in patients that are young and healthy. And of course, we'll talk a little bit about microsatellite unstable patients and immunotherapy. So you would think that there would be a ton of data about perioperative chemotherapy in the literature, and there isn't, unfortunately, because it's been very hard to determine whether or not it's beneficial to patients. This is the EORTC 40983 study, and this looked at FOLFOX in metastatic deemed resectable colon cancers where they had less than 3 liver lesions, and patients were randomized to receive FOLFOX surgery followed by FOLFOX for a total of 3 months before, 3 months after, in a sandwich fashion, versus surgery followed by adjuvant therapy. The primary endpoint was progression-free survival, and the secondary endpoint was overall survival. And what we found was the primary endpoint was met, and progression-free survival actually is a very good surrogate marker for overall survival. But the 5-year overall survival was not any better between the chemotherapy upfront neoadjuvant or perioperative chemotherapy versus the adjuvant chemotherapy. So like I said, it's much harder to determine whether or not this benefits our patients. And there have been several other smaller studies that have been conducted, some from Japan and from Europe, and they all pretty much show the same results. Now, what about 3-drug regimen? Now, we talked about FOLFOXIRI, the triplet regimen, showing a superior overall survival over sequential doublet therapy. That means, switching chemotherapies around. You also have a higher response rate in these patients. So this is a study that actually had a planned secondary endpoint, which is R0 resection, and compared FOLFOXIRI versus FOLFIRI. This is the GANO group. And it did prove that, the triplet therapy was superior to doublet therapy, the FOLFIRI. It showed a higher response rate, a better progression-free survival. But when they looked at surgical outcomes, you could see a higher rate of R0 resection, almost double in the triplet arm versus the doublet arm. Especially in liver-only disease, you could see a much higher R0 resection in the borderline resectable patients. And treatment with FOLFOXIRI, the 3-drug regimen, was an independent predictive factor of R0 resection. So we tend here at KU to really use the triplet therapy as our standard of care in patients that are healthy, that can tolerate some mildly added toxicity. Now, they also looked at quality of life in these patients. And because we got their cancer under control, most likely, they all had pretty similar quality of life across the board. So I think that's what we prefer to do at KU in robust patients. Well, that's chemotherapy. What about targeted therapy? We know that there are EGFR inhibitors, there's VEGF inhibitors, we've talked about CTLA-4 inhibitors and other checkpoint inhibitors, BRAF inhibitors. There's a lot of this stuff that's being developed. Any of it have a role in the perioperative setting. So this is the first study that I wanted to talk to about. And I think this is also to show us that we are actually dealing with multiple diseases or different diseases. The FIRE3 study is a German study. It looked at metastatic colon cancer. These patients were randomized to receive FOLFIRI, a doublet therapy plus cetuximab, versus FOLFIRI plus bevacizumab. So we didn't know which biological agent was superior to the other. The primary endpoint was overall response rate, and this is when we started noticing that KRAS mutated patients did not respond to EGFR inhibitors, so they were starting to exclude them in 2008. So some of them were actually KRAS mutated when we started the study. And what we could see is actually the overall survival was superior in the patients that received the cetuximab plus chemotherapy arm. So this led to Europe adopting this regimen as their go-to regimen. And everybody with metastatic colon cancer eventually went on FOLFIRI cetuximab in Europe. And you could see the overall survival was definitely favoring patients with cetuximab when they looked just at the RAS wild type patients. But this is something that will help determine some of the disease biology as we go along. So then this big argument came out between Europe and the US. US was using FOLFOX upfront, and Europe was on the FIRE3 study bandwagon, and they were only using FOLFIRI cetuximab for the KRAS wild type. If they're KRAS mutated, they were giving them FOLFIRI bevacizumab. So this is a international cooperative group and was one of the largest studies in metastatic colon cancer that was conducted over a decade. So this was 10 years follow-up. And they did FOLFIRI versus FOLFOX plus bevacizumab versus FOLFOX or FOLFIRI plus cetuximab. And they switched them up. And they said, dealer's choice, whatever you want. We just have to make sure it's balanced. And they wanted to see which doublet therapy plus biologic was actually the winner to start all of our colon cancer patients on. And they found that it was equivalent. None of them were better than each other. If you started FOLFOX versus FOLFIRI, didn't matter. Bevacizumab, cetuximab did not matter, except we had noticed over a long time ago that patients with right-sided colon cancers always had worse outcomes. We didn't know why. And we thought maybe, the right side of the colon was large and the mass would get bigger, bleeding would disappear in the stool, unlike the left-sided colon where you'd see the red fresh blood, and people get scared and they get their colonoscopies. And that's why right-sided colons would progress faster and metastasize before they're detected. But we also realized that the right-sided colon and left-sided colon come from two different embryonic origins. And this difference in survival between right-sided and left-sided colon cancer was noticed in multiple studies over different agents. So they went back on the study and actually looked at right-sidedness versus left-sidedness. And they found there was a significant improvement in survival if you had left-sided colon cancer versus right-sided colon cancer. Now, these are the patients that received bevacizumab, which is a VEGF inhibitor. And they found that even then, left-sided colon cancers would do better than right-sided colon cancers. And there was a statistically significant improvement in survival. But look at the left-sided colon cancers that were RAS wild type and received cetuximab. You could improve these patients' overall survival by about 20 months. So very interesting data. This is kind of the summary of those different survival curves. And they went back to the data, the FIRE3 study, and they actually compared the data side by side. And it also showed a 20-month improvement in survival in left-sided colon cancer. So this is leading to us determining that we are always treating colon cancer as one disease, but all of our studies now are actually stratifying these patients according to right and left colon cancer. We know that the right-sided colon cancer profile, the genomic profile, is very different from the left-sided colon cancer genomic profile. Even the microbiome in the colon is different from right to left. And I think that's where we have to take that in consideration going forward. And a lot of the studies that we've conducted and completed at KU, like the PANET study looking at a triplet therapy plus EGFR inhibitor in left-sided KRAS wild-type tumors to see if we could convert some of them to resectable or improve their survival, are ongoing, and we're waiting for those results to come out. Hopefully indicating treating right versus colon is a little bit different and maybe getting a better response by using certain targeted therapies in these subgroups or different populations. Well, let's go back to this microsatellite instability stuff. We know that this is more commonly seen in stage 2 disease, but you still can see it in stage 3, and it's really rare in stage 4. The very odd thing about microsatellite instability is in stage 2, they have an excellent prognosis. Their cure rate with surgery is almost 100%. Now, in stage 3, we're not sure. So that's why we just finished the study at KU looking at chemotherapy plus immunotherapy. It was an alliance study, and we're waiting for that to result. But we know in stage 4 disease, they had horrible outcomes. The biology of disease was much worse once they developed metastatic disease. They wouldn't respond to even triplet therapy, and it was very short-lived, their response. So that led to the use of just checkpoint inhibitors in these patients. And from these smaller studies, we could see that there were very good response rates overall. You could see that there were even CR rates in some of these patients, and you had some durable disease control rates, very long disease control rates. And this led to the Keynote 177 study. So we always started with chemotherapy in these patients, but this study was there to answer whether chemotherapy was superior to immunotherapy in the upfront setting. And the pembrolizumab was compared to dealer's choice chemotherapy. That's FOLFOX, FOLFIRI. They didn't use a triplet. Now, they should have used a triplet, but they didn't, because we usually use triplets for microsatellite unstable cancers. But they allowed crossover because I don't think it would be ethical to not allow crossover. Most of these patients will end up getting immunotherapy anyways. So overall survival was probably a shaky endpoint from the beginning. But progression-free survival was their primary endpoint. And what we could see here is you could see that progression-free survival was favoring the patients that received pembrolizumab, and it was way superior than chemotherapy. And you could see that tail of the curve just kind of extending outwards, as you see with a good response to immunotherapy. So this basically led to the change of standard of care. You saw a very good durable response rate with some CRs in these patients. And I think even if we watch these patients a little bit longer, you'll see the CR rate go up even further. But a lot of these patients, like I said, did cross over from the chemotherapy arm into a different immunotherapy. So overall survival is still being looked at, but it may not be positive, as most crossover studies show. And this is the duration of response. You could see a very durable response in a lot of these patients. So this led to a lot of things that Dr. Luca alluded to is, we even in metastatic or very locally advanced disease, there are ongoing studies looking at pembrolizumab and checkpoint inhibitors in trying to in the neoadjuvant setting to converting these patients to surgical candidates, or even non-surgical candidate, or avoiding surgery altogether and radiation altogether, like the dostarlimab study that showed a complete pathological response in rectal cancer patients with microsatellite instability when they received dostarlimab, and they could go on a watch and wait approach. And I think next up is Dr. Luca about surgical techniques.
Yeah, so I'll go through this quickly because I do want to allow at least a few minutes for questions at the end. But I did want to kind of go through, again, surgery is, out of all of these multimodality options that we have, surgery has been, more or less the main one that stayed the same for the longest. So there's not much evolving, but we're gonna talk about what the standards are and what small things may be changing, or at least trending towards how we can get better results for our patients long term. The goal of all these things, like we said, minus possibly giving immune therapy to have a complete response and avoid surgery altogether. Whether you have locally advanced cancer, whether you have metastatic cancer, getting you to a point where you can get an R0 resection and get you as long of a disease-free and overall survival as possible. And so just to recap your oncologic principles that we've had for decades and decades now. For colon cancer, again, you want 5 centimeters proximal and distal. And this is not necessarily for spreading of the lesion itself, but that's as wide of a lymph node basin as you need for those lymph nodes directly underneath and adjacent to the mass itself. You want at least a 10 to 12 centimeter wide basin of the lymph nodes, all the way down to the origin of the main feeding vessel. So that's how you get all of your lymph nodes. Sorry, can you go back one more, right? And we'll get to that in just a second. Of course, you want to keep the mesentery intact, and then the whole goal of this is getting at least 12 lymph nodes. So that's what those 5 centimeter margins for, and going to the base of the feeding vessel. So if you look at the anatomy here and the next slide, that's kind of where we get our principles from. You can see here, if you're going a right or an extended right colectomy, you want to get the origin of the ileocolic artery, the right artery, which is variable, of course. So the ileocolic, and then the right branch of the the right branch of the middle colic artery coming off the SMA. You want the base of those to get your lymph node basin here. We're going to skip this for a second. And then this is a super extended right, or subtotal if it were. But generally speaking, we don't do that for these cancers over here. We'll go to a left, anywhere that's in the left colon or the splenic flexure. You want to get the base of the left colic. And then, of course, for your sigmoid colon cancers, technically speaking, you don't have to go to the base of the IMA. You do want to get the left, and you want the base of the superior rectal. Most of us, technically speaking, do try and get to the base of the IMA because that's the easiest way to, of course, get the left and the superior rectal. If you just take the IMA at its base, you're going to get all of them. But the goal is, of course, to get all the lymph nodes. Now, going up to this upper right-hand corner, this didn't exist when I was a fellow, just 6 years ago. When I was in training, residency, and fellowship, this was a big no-no. I was taught by all of my colorectal attendings to not do a transverse colectomy. The thinking was that you're going to end up having to mobilize much more, and you're going to end up putting these two watershed areas together. Even though the hepatic flexure isn't technically watershed, you've probably taken both branches, the superior, of the middle colic and the middle colic at its base, and now you're going to take this watershed area and anastomose it to this watershed area, and it's going to lead to all kinds of problems. Since then, we've kind of learned that that's not necessarily the case. The data has not hashed that out. And so now this is, and I have another slide on that, but we're going to get to why a transverse colectomy in certain patients, of course, is a very viable option. So if we go to the next slide, we'll see that that's what I'm talking about. So the right colons, the left colons, the sigmoids, those have all been kind of the same for many, many years. Very recently, we have a lot more data on transverse colectomy. And so there has been several research studies that showing that these patients have fewer postoperative complications, the most significant one being anastomotic leak, which is the one that we were always worried about with the transverse colectomy. And they do actually have improved 3-year disease-free survival. I don't know if that's because you're doing a transverse colectomy, so you're only going to get your 12 lymph nodes by going all the way down to the base of the middle colic. Whereas, if you're doing an extended right, you're going to get 12 lymph nodes either way. So maybe you're not as cautious about getting all the way to the base of that main feeding vessel. But whatever the case is, the anastomotic leak rate makes sense. Why we're having improved disease-free survival, not quite sure. But the point is that at the minimum, it's non-inferior, but a lot of this data would suggest that it's actually superior to doing an extended right or extended left. There's another study that showed that the 5-year survival was similar for either an extended right or left versus a segmental, which would be an isolated transverse colectomy. But when they did a little bit more advanced analysis, the extended colectomy was actually associated with lower survival. So all of the outcomes do seem to be better when it is possible. Now, if you go back to that picture on the slide before, if your transverse colon looks like this, probably not a great idea. So it really should be isolated to patients who have a very droopy transverse colon, and this mass is right in the middle of it, where you're not having to mobilize the entire right side and left side to get your 5 centimeters and then do your anastomosis. So it is going to be reserved for selected patients, but if you can get to the base of the middle colic, get your good lymph node basin with a nice tension-free anastomosis, all the normal surgical principles that we rely on, then it is a very good, and with some studies would suggest superior surgery to do an extended right or left colectomy. If we skip ahead to then we'll see. So what about the other principle that is the big debate these days about extended lymphadenectomy? So the standard of care now, like we said, go to the base of the main feeding vessel. So the ileocolic on the right, basically speaking, and the IMA or the left colic on the left side. What about doing an extended? So this idea comes out of mostly Asia, where they've been doing extended lymphadenectomies, or D3 lymphadenectomy, as it were, for a long time as their standard of care in lots of different GI cancers. It's been their standard for stomach cancer. It's been their standard for colon cancer for a while. And that's where a lot of the data comes out. In the US population, the European population does this kind of hash out that we should be doing that, because that's not what we do. Our standard is a D2 lymphadenectomy to go to the base of the feeding vessel. So D3, strictly speaking, also known as a central vascular ligation or extended lymphadenectomy, that's going to the base of the superior mesenteric artery. If you have a right-sided or a transverse colon cancer, you actually skeletonize the SMA and take every single branch of it going to the colon along your lymph node basin. If you're on the left side, it does involve going all the way to the base of the IMA and kind of skeletonizing it right off the aorta and taking it right there on its base, and then following it up and then taking the IMV, not necessarily closer to the IMA, but really getting all the way up at that inferior edge of the pancreas and taking it there. So does that provide better outcomes? The important thing to remember is that when we talk about a CME, or a complete mesocolic excision, that's not the same thing as an extended or D3 lymphadenectomy. CME is what we do. Everyone is a proponent of that. That has more to do with the completeness of the envelope, kind of like we talked about a TME with rectal cancer, just the completeness of your excision, not having divots or incomplete shredding of your mesentery. If you take out the mesentery in one intact envelope, as it were. And so we do want a complete mesocolic incision. It has nothing to do with the where those lymph nodes go all the way to the base of the feeding vessel. It just means the completeness of having that those lymphatic vessels intact and taking them out en bloc with your colon without a bunch of chunks or divots taken out per se. And so we know for D3 lymphadenectomy, it produces higher lymph node yields, of course. Instead of getting 12, 13, 14, you're going to average 20, 25, even 30 lymph nodes, which will improve your staging in theory. If you have positive lymph nodes, might give you a couple more positive to take you from an N1 to an N2 or N2 to an N3. But does that have clinical significance? Are we finding N0s that we're turning into N1s? What's the question of skip nodes? And then what's the story of the increased complications? So I'll get a couple studies that were shown later, which will be on the next slide, which we'll get to in a minute, have shown that there's isolated studies that show there is somewhere between 0 and 3 to 4% where you will have 0 positive lymph nodes within your CME of a D2 lymphadenectomy. But if you do a D3, there will be quote unquote skip nodes where there's a positive node at the base of the SMA that you wouldn't have gotten with the D2. And so now all of a sudden you have an N1 patient where you would have just had an N0 if you had only done your standard resection. Again, 0 to 4% in some isolated studies. I'm going to present some other data later that shows that maybe that doesn't hash out in all of the data. And so are skip nodes really a thing that we see in clinical practice? That's still a question. The other thing is that every single study has shown that there's an increased risk of complications by doing a D3 lymphadenectomy. Obviously, the main one that you can imagine is increased risk of vascular injury. So you're skeletonizing the aorta on the left, you're skeletonizing the SMA on the right. Obviously, there's going to be increased rates of arterial injuries or those arteries bleeding through your staple lines or your sutures or whatever it is used to ligate those vessel pedicles. So if we go to the next slide, we'll see that there is more data that shows that if you do have D3 positive lymphadenopathy, there's of course a decreased recurrence-free survival. So this comes out of a very, very large study in Japan where they did D3 lymphadenectomies on every single patient as their standard. And you can see across the board between all end stages and all stage 3 stages, all 3 stages in general, if you had a positive node in your D3 basin, that was associated with decreased recurrence-free survival versus if you did not have. So all of these are statistically significant. What the main outcome that was interesting to this, if we go to the next slide, is, oh, I'm sorry. That was actually on the slide before. I apologize. What this showed was that this study, and there were 3 or 4 other studies that came out of this that were kind of copycat studies to try and get the same data. Every single patient with these, there was not a single patient in any of these studies that had a positive D3 node that didn't also have positive nodes in their D2 lymph node basin. And so while they did have decreased survival, you already knew that these patients did have nodal disease because you would have caught some of those positive nodes in the D2 lymphadenectomy specimen. And so these patients would have been treated by adjuvant therapy anyway. And so clinically significant, they did get therapy, but again, these patients all had those D3 lymph nodes resected and still had the worst outcomes. So is it really changing their long-term clinical course because they all got chemotherapy anyway? So whether or not you got those lymph nodes out or not, with the adjuvant chemotherapy, I'm not quite so sure that that's going to improve your outcome. Is it worth the risk of having those vascular injuries, taking those extra lymph nodes, if it's not going to necessarily improve outcomes? And so, this is just in my opinion. I think this is, when we talked about prior, the neoadjuvant chemotherapy, and it may only be useful for advanced T4 lesions in your stage 2B diseases. And I said it might not be useful for obvious lymphadenopathy if there's not locally advanced T4B disease. This might be the one caveat where I would say there may be an indication for neoadjuvant chemotherapy to downstage these. I don't think that an extended or a D3 lymphadenectomy, in my opinion, is worth it as standard of care. But we do have those occasional patients where there is those radiographically positive nodes outside of your standard field. There's pericaval nodes, or there's periaortic nodes outside of your field. And so I think those patients may deserve a trial of that kind of sandwich therapy that Dr. Al-Rajabi was talking about. And we do have clinical trials going on at KU to kind of look at that. So if you have your standard nodes and you do have that positive that radiographically positive node outside of your standard field, to decrease that risk of having to go cherry pick it and possibly have a caval injury or an aortic injury, that those 4 to 6 cycles of neoadjuvant therapy to possibly downstage the patient, not leave them with that risk of worse recurrence. If you can downstage it with the neoadjuvant and then do your standard resection before you get the adjuvant therapy, that may be the patient that benefits from that, even without your risk of a technically R1 resection as far as the primary tumor is concerned. And so then, last but not least, I won't spend too much time on this. But again, as we get further out into robotics and things like that, I'm not necessarily promoting robotics. I do a lot of robotic surgery myself, as well as laparoscopy, but there's very strong evidence for the minimally invasive approach. And so again, like we talked about with neoadjuvant therapy, if that's kind of required to be able to shrink a tumor enough where it's worth it to do a minimally invasive approach, right? Because one of the relative contraindications to doing something minimally invasive is, well, if I have to have a 15 centimeter incision just to extract my 15 centimeter tumor, then what's the point? And that's totally valid. So if you can have some tumor response, some downstaging, things like that in order to make it worth it, then that may be worth it as well as far as neoadjuvant therapy. So I only highlighted one study here, and I do apologize. I forgot to put a citation at the bottom for this trial, this color trial. This was back in 2008, I believe, and then this is what I presented here was the 10-year follow-up, which was, I believe, was published in 2018. This is the largest study we have. There was a concurrent study going on in Australia, which basically showed these same results. This one was in Europe. It was in 29 cancer centers across Europe. I think it was run by the Dutch consortium, but this was all over Europe and showed significant disease-free and overall survival, statistically equivalent to open surgery. So there's been many studies since. I have only highlighted this one, but whether it's laparoscopy or robotics, the outcomes are equivalent, obviously for safety, efficacy, and then the short-term benefits of pain and recovery and all of that. But as far as an oncologic outcome, we do promote doing a minimally invasive approach when at all possible. And so that's kind of what's going on with any updates or controversies in the actual technical surgical approach these days.
All right, I'll be quick about the studies that we have at KU. This is one of the studies that was developed with the collaboration of some of our industry partners. This is looking at targeting the microenvironment with SIND1 and inducing these transcytosis and delivering the chemotherapy agents a little bit more efficiently to cancer cells. This was developed, or basically for early phase studies showed really good disease control rate, overall response rates with a progression-free survival of 9.7 months. This led to our study that was developed by Dr. Kasi, and looking at oligometastatic disease in colon cancer, and this is accruing patients here at KU. It was funded by a KU-CCEP pilot grant, and this is the title. We have several other studies. I'm not going to go into the details, but like we said, we're looking at how do we monitor these patients once they survive? How do we detect the risk of recurrence, and who are the patients that really need chemotherapy? We're also looking at combining immunotherapy plus VEGF inhibitors to improve the immune response in patients that are microsatellite stable, looking at targeted agents like KRAS inhibitors, using other things like HIPEC, and using inhalational versus intravenous anesthesia. We think that may also show some benefits in the curative resection. And a plug for our KUCC Clinical Trial Finder. This is an app that we developed at KU. You could download it from the Apple App Store or Google Store, and it actually lists all of our studies that are updated in real time. And I think that's it. Thank you very much for your attention. We can take some questions now.
All right, thank you both. That was fantastic. For the participants, if you want to unmute yourself to ask a question, or if you want to put questions in the chat box, feel free to do that as well. I'll get us started and ask with the so with the Fox trial and the Prodige or Protege trial, you know, it was interesting, Dr. Al-Rajabi, you mentioning, of course, the difference in survival rates of left colon versus right colon, and these are probably two separate biologies. Do those studies looking at neoadjuvant treatment, did they separate those out, left colon versus right colon? Is there maybe a subset where you would be more likely to use it because you're expecting a better response?
So with standard chemotherapies, you know, what they're doing now is they're balancing the two groups by when they include or randomize the patients, they're stratified according to right and left colon. I think where it makes a big difference is the EGFR inhibition. That makes a dramatic change in outcomes in patients. And yes, we're definitely looking at that in the neoadjuvant setting. I think studies have already been completed in consortiums looking at left-sided colon cancers, wild type, HER2 negative, that are getting EGFR inhibitors. What's the resection rate? What's the survival rate? But right now, all of our studies are actually balancing. It's a stratification, so it's part of you should have the same exact number of lefts on each study arm, because it definitely makes a difference.
Yeah, in those two trials, the Foxtrot and the Protege, again, I don't think there's been published 5-year data, but based on these newer studies that Dr. Al-Rajabi is talking about, I think, if they're able to make it to the 5-year data and have any kind of power on them, they may start looking at those. When we see the 5-year data on them, they may, if they have enough patients to hash those two out. Again, we only have 2 and 3-year data for both of those because they are pretty recent studies. So I think we'll see the longer term data. Maybe we'll get subset analyses.
Great. Another question that I had, we'd had in some of our prior talks, looking at breast cancer and immune therapy. And so specifically like Pembro in the neoadjuvant setting, seeing autoimmune responses and even some of the endocrinopathies. So they've seen, perioperatively in some of those patients treated with those regimens, even adrenal insufficiency upon induction. I didn't know if that's anything that you've seen as much in the colorectal data or literature. Granted, the neoadjuvant setting for this isn't as robust.
It's a big issue with immunotherapies. It's just everybody loses their thyroid function. That's what I tell my patients. If you're on immunotherapy long enough, you're probably going to lose your thyroid function. So, they're not surprised that they're starting on Synthroid or something like that. But yes, we see it a lot. We see a lot of autoimmune colitis and hepatitis. But the good thing is we've been using immunotherapy now for maybe 9 years with the melanoma and even closer to 10. I think when I was a fellow, ipilimumab was just coming out, and we're really comfortable using different agents to stopping these side effects. And the good thing is they are mostly reversible, and the likelihood of long-term effects are low, except for the endocrinopathies. Those really don't go away.
Yeah, it's actually interesting too, because for the patients that we do use them on, we're finding more and more such a good response in colon cancer. Obviously Riot sees this a lot more than I had. One patient with rectal cancer. They got 2 doses, and I can't remember which agent it was, but he had 2 doses of immune therapy, and he had a really bad immune-mediated hepatitis, which again resolved over several months. But with just those 2 doses of immune therapy, he had a complete response to his rectal cancer. And so now he's just in watch and wait just from the 2 doses. And so, I think, like Dr. Al-Rajabi said, it's a big problem. You got to build the patient expectations of what the expected side effects are and what the probabilities are. But I think a lot of patients, if you start showing them some of this data, they're probably willing to do that with such a good response. And again, with the microsatellite unstable, especially cancers.
Yeah, and the patients that get the severest side effects actually do the best. So, it's usually just like Sam said, it's usually a good sign, and they'll have a durable response.
Great, thank you. Any other questions from any of the other participants on the line? All right, while people are potentially thinking about some follow-up questions here, I did have just one more item to relate to the group. So for those with Commission on Cancer status, if you're part of your cancer committees for the COC, there's an upcoming webinar. It's this week, so it's Thursday, December 7th, and it's at 12 p.m. These are recorded, so it's over the lunch hour. These are recorded and usually released a week later. But for standard 5.8 for the lung cancer resections and lymph node harvest, that's been a difficult one for all the sites to meet the compliance with that with. So there is going to be a new study. And this, again, will be a quality improvement project that the COC is rolling out for all sites. If you don't have the sign-up link for that and you're interested, please feel free to email me. It's just jmcallister@kumc.edu, and I can forward the sign-up for that if you'd be interested in attending. All right. Well, if there are no other questions, Dr. Luca, Dr. Al-Rajabi, thank you so much. It was a fascinating talk. I'm sure everyone will have follow-up questions after we percolate on the information a little bit more. And again, for all those in attendance, this will be recorded so that you can go back and watch it after the fact. If you're interested in that, we can send a follow-up email with the link. Again, it's usually a week or two before those are posted online. So again,
Well, thank
thank you both very much.
Yeah, appreciate the time, Dr. McAllister. Thank you.
Thank you for having me, and